Hello, everyone. Hello, hello, hello. Please tell me if you remember me. Good morning, everybody. Okay, I remember some of you from the crash course. Okay, guys, this is Amro. For those who do not know me, I will go with you through some of the high yield GIT facts, and we will do some GI questions at the end. But before jumping in, I want to tell you about um some of the services that we provide. Guys, we at the Match Guy, we take you from A to Z. We take you from USMLE Step 1 preparation till the match, till USMLE Step 3, and even the match. Okay. Today for USMLE Step 1, guys, we have many resources for you. We created the Match Guy high yield files, which are files condensed and focused on the high yield contents only, not everything. Not everything. Guys, I see a problem in the market with USMLE courses and USMLE QBanks. Step 1, as you know, became pass or fail like 4 or 5 years ago. What should be expected is QBanks and courses, they cut down. They cut down the content, the hours of the courses, the questions of the QBanks. Why? Because step 1 became easier. You just score 70%, okay, and you're safe. But what we noticed is courses increase the size year by year, months by months, they increase the size. QBanks are increasing questions. That's why we created the high yield files focused only on USMLE Step 1 exam, okay? Helping you to pass a Step 1 exam as soon as possible. We created the Synapse QBank, guys. I will show you the QBank later. Focus only on high yield content. It is like 1,300 questions. Only the high yield questions enough to pass your USMLE Step 1 exam. Okay, guys? All right. Plus, we have the crash course, which is condensed course we hold in 1 week, like 50 hours, 7 or 8 hours daily. In 1 week, you finish all the Step 1 content in 1 week. Okay? Also with the same concept, only the high yield. Because, guys, there is a rule called 80-20. Like, I wanna prepare for a certain exam, okay? And I have limited time for preparation. I have limited time. So I should follow the rule 80-20. What is 80-20? 20% of the content are asked 80% of times. So when I start, I should focus on the 20% first, not studying randomly, which we considered in our course, guys. Okay? We focused on points that are asked 80% of times. That you will find that in our files, in our crash course, or in our QBank. Clear, guys? We also, guys, we have mentoring program. If you want a mentor, and by the way, I suggest that I learned Spanish this period, guys. I learned Spanish. I did not think much. I'm a tutor, I'm a USMLE tutor, and I appreciate mentoring and how mentoring and tutoring save time and effort. Immediately, I hired a tutor, a Spanish tutor. Okay, guys? The tutor saves my time, saves my effort. He just tells me your homework today is ABC. This is it. Thank you. I will not think too much. So if you're interested in tutoring, guys, working with a tutor with long experience in tutoring with many success stories, we have like too many tutors with different experiences. You can book free meeting. First meeting is free with two tutors. You give them your problem. You see the solutions and the suggested plans. And if you like the tutor, you can subscribe, and anytime you want refund, guys, you can take your money either in the QBank, the crash course, the tutoring, because yes, we aim at benefiting you. Okay, let me share my screen. Okay, guys, let us start. Okay, guys, before starting, how should you study for GIT? Okay, how should you study for GIT? For GIT, guys, I need to tell you 2 points before you start. From my experience, I went through all the self-assessments in the market. In GIT, they ask like 15 to 20 questions. Let's say an average of 15 questions. Average of 15 questions, okay? In those 15 GIT questions, I noticed that there are fixed 10 questions. Okay? Fixed 10 questions. Those 10 questions, guys, will come in those topics. So let me tell you about those topics. Okay. Let me write them here, guys. The 10 topics that you must see in each assessment. Number one, each assessment, my friends, you will have a question about GERD, reflux, reflux. And it is either risk factors of reflux or outcomes like complications, complications of reflux. That is topic number one. Number two, peptic ulcer disease. Peptic ulcer disease, they will ask about the risk factor, the pathogenesis, how each risk factor caused the ulcer, and three common complications. We will cover later together. Three common complications. Each assessment, my friends, will have a question from regulation, arrows question. Vomiting against diarrhea. Vomiting against diarrhea, like acid-base balance, what is the level of bicarb, what is the level of chloride, potassium, okay? Number four, number four. Um, each assessment will have a question from cirrhosis-related complication. Mostly, hepatic encephalopathy and shunts. And treatment, you know, let's say hepatic encephalopathy, risk factors, and the treatment. Okay, to be more specific. Number five, each assessment will have a question from biliary disorders, especially cholecystitis. Biliary disorders, especially cholecystitis, okay? Number six, each assessment will have a question, my friends, from pancreatic disorders, pancreas, especially chronic pancreatitis, followed by cancer, followed by pancreatic cancer. Number seven, each assessment will have a question from fatty diarrhea, my friends. Fatty diarrhea differential diagnosis. Fatty diarrhea risk factors. Risk factors, like what I mean by risk factor, the diseases that lead to fatty diarrhea, like chronic pancreatitis, celiac disease, and the complications. What would happen if there is fatty diarrhea? Number eight, cancers. The cancers that I saw asked: colon number one, colon cancer and neoplasia, and also colon benign tumors, followed by pancreas. Colon followed by pancreas. Okay. Number nine, inflammatory bowel disease. Mostly ulcerative colitis. Like 60%, 65% of assessments ask about ulcerative colitis. 30% ask about Crohn's. Last question, pharma. Literally each assessment I saw ask a question from proton pump inhibitor. Mostly the mechanism of action of proton pump inhibitor. Clear, my friends? So before diving in GIT, those are the high yield points that should take your priority when you study. That's why I'm telling you 80-20 rule. 20% of the content is asked 80% of times. That is number one. Number two, the second point I want to tell you about, guys, is how you study for GIT. GIT for step one, mostly families. The disorders, the diseases are families, guys. And how you study family? You study family by memorizing the general symptom or the general picture. I call it the general picture of the family. Then each member of the family will carry the general picture plus specific key. Like subtype A has key A, subtype B has key B, subtype C has key C. Let me give you an example. The first family in this question, my friends, is neonatal vomiting. You need to know how generally the neonatal vomit present and the acid-base disturbance. Uh, and each subtype of the family has a specific key. Duodenal atresia, first subtype, has its own specific key. Pyloric stenosis has its own specific key. Tracheoesophageal fistula, it's a specific key. Why am I highlighting on the specific keys? Because I met too many students before, guys, telling me, Doc, I exclude all the answers. I exclude choice D. I exclude choice C. I exclude the choice E. Then I am confused between A and B, and it ends with picking the wrong one. I think I have problem with test taking strategy. No, this is not test taking strategy. This is gap, knowledge gap. Okay? This is a subtype of knowledge gap. You lack the specific key. You do not know that duodenal atresia has certain key, pyloric stenosis has a different key. If you memorize those small specific keys, you will answer easily. And when you study, my friends, like I'm studying a topic like that, where is the specific key? Where is the differentiating point here that make me choose this and neglect all other choices? And this is what I will do with you today, guys. Let us start. I will read the question. I will give you 5 seconds to think. Then I will give you my answer. Guys, you have a full-term newborn begins choking, coughing, vomiting immediately after the first feed. The infant also develops excessive drooling and intermittent cyanosis during feeds. On physical exam, there is mild distension. An esogastric tube is inserted but meets resistance and coils in the proximal esophagus. What is the most likely next step? Exactly, my friends. That is tracheoesophageal fistula. This is the first family we will have today in GIT, guys. The family of neonatal vomit. The family of neonatal vomit. This is the first member of the family, tracheoesophageal fistula. Look here, guys, what you see. I see fistula and the connection between the distal esophagus and the trachea. The distal esophagus and the trachea, and the proximal esophagus is blind. Blind. Okay? So what happens is the baby has the first feeding of life. The milk accumulates here, 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 here. Then the baby vomits. To master this family, guys, you ask yourself two questions. When when did the vomit occur? Number two, what are the contents of the vomit? Let us apply my questions here. When did the vomiting occur here? The vomiting occurred after the first feed of life. The first feed of life, hours after delivery. Okay, what are the contents of the vomit? Milk. Milk that is not digested because it did not went to the stomach. Milk that is not digested. I can say pure milk. Clear, my friends? That is tracheoesophageal fistula. What is your next step? You will insert nasogastric tube. Nasogastric. I'm expecting to see it in the stomach on imaging. When you insert the tube, you will you will meet resistance in the middle. Okay? You order X-ray, you will find your tube coiling here in the chest. Coiling in the chest. That is tracheoesophageal fistula. Clear? That is tracheoesophageal fistula. All right. This defect, my friends, is present since fetal life. Fetal life. So I saw them asking once before about its association with polyhydramnios. Polyhydramnios, right? Any defect, any obstruction in the GIT, my friends, is associated with polyhydramnios, right? And this is a specific key we can use later to differentiate members of the family, right? That is tracheoesophageal fistula. Next, we are still in the family. A 4-week-old firstborn male presents with projectile non-bilious vomiting. The exam reveals a firm olive-shaped mass in the epigastric area with visible gastric peristalsis. Labs show metabolic alkalosis. What is the most likely diagnosis? Yes, yes, yes. Pyloric stenosis. We are still in the family, guys. We are still in the family. We are still in the family. Pyloric stenosis, one unlucky neonate male, especially if this male is treated with erythromycin, especially if this male is formula fed, okay? Especially if this male is formula fed, there will be hypertrophy of his pylorus, hypertrophy of the pyloric sphincter, hypertrophy of the pyloric sphincter. So what will happen? Obstruction. of the stomach outlet. So that will lead to vomiting, projectile vomiting. Stomach tries to contract in the down direction. This responds back by reverse peristalsis, vomiting. Let us apply my questions. When did the vomiting occur, guys? My questions. When did the vomiting occur? Hmm. This pylorus took time to develop. It took like 1 month after delivery. So it will be like between 2 to 8 weeks. 2 to 8 weeks. It took time. So it developed after delivery, my friends. So the fetus was normal. So no polyhydramnios, right? So I can use polyhydramnios to differentiate pyloric stenosis from tracheoesophageal fistula. Okay. Now, what are the contents of the vomit, my friends? Contents of the stomach. Milk, but digested, plus non-bilious. Non-bilious. Non-bilious vomit, plus the milk is digested. Clear, guys? All right. Me as a physician, I will examine the baby abdomen. I will palpate the pylorus, guys. I will palpate the pylorus. Hypertrophied pylorus. USMLE describe it as olive-shaped rounded mass. Olive-shaped rounded mass. Clear? Olive-shaped rounded mass. That is hypertrophied pylorus. Okay. In addition, um, next step, you will order ultrasonography. Ultrasonography will show you this picture, and it is asked in one of the self-assessments, by the way. Picture like that, hypertrophied pylorus. You need to memorize it, my friends. You need to memorize it. Okay? You need to memorize it. Elongated hypertrophied pylorus. That is pyloric stenosis. When did the vomiting occur? 2 to 8 weeks. The hypertrophy occurred after delivery. Okay, so no polyhydramnios. Unlike tracheoesophageal fistula, it had polyhydramnios, right? Okay. Um, Before going to the third member, my friends, before going to the third member, I want to highlight one of the most high-yield GIT questions for USMLE: vomiting. This infant has excessive vomiting. What is the disturbance, acid base and electrolyte disturbance that he will have? Super high-yield question, guys. Vomiting. Excessive vomiting means loss of too much HCl, right? That is the first point. Losing HCl means losing chloride. HCl, chloride. Whenever you lose chloride, guys, the body retains bicarb because both carry negative charge. If you lose one, the second goes up. Too much bicarb means alkalosis, metabolic alkalosis, high pH. Losing too much fluid, guys, activates the RAS system. You know the RAS system ends with aldosterone. Too much aldosterone action decreases potassium. Arrow question, guys. Arrow question. Super high yield. This is vomiting. Let us cover diarrhea in our way. Diarrhea, my friends. Diarrhea means what? Loss of the intestine contents. Intestine contents rich in bicarb, right? Losing bicarb means what, guys? Means chloride would go high because they are opposite. Okay? And losing bicarb means acidosis, low pH. Diarrhea for long time, my friends, activate the RAS system. RAS system, as we said before, leads to hypokalemia. This is the regulation. Literally each assessment, 60% of them, they ask about the vomiting regulation, 40% ask about the diarrhea regulation. Clear, my friends? Okay. Let us go to the third member of the family. Duodenal atresia. Duodenal atresia, my friends. There is atresia here in the duodenum. There is atresia here in the duodenum. This is a fetal problem, my friends. Failure of duodenal lumen to canalize. Failure of duodenal lumen to canalize. Okay, so what will happen? GI obstruction, as you see. GI obstruction in fetal life, so polyhydramnios, right? That is number one. Since it is in fetal life, it will come early. It will present early after delivery. The baby will vomit. Let us apply my question. When did the baby vomit? When does the baby vomit? The baby will vomit in the first 2 days of life, maybe in the first day. Early. Early. What are the contents of the vomit? Bile. Bilious vomiting. Because, guys, obstruction at duodenal level or down gives bilious vomiting. Clear? You order X-ray, guys. You order X-ray. Whenever you see bilious vomiting in a child, or in anyone bilious vomit. Next step is X-ray. This is a common question in GI step 2. X-ray will show gas bubble here in the stomach, gas bubble here in proximal duodenum, double bubble sign, double bubble sign. Clear, my friends? Double bubble sign, double bubble sign. Okay, that is duodenal atresia, my friends. All right. It is highly associated with Down syndrome. There is for USMLE step 2 students who watch us. Guys, for pyloric stenosis, it needs surgery, right? But before putting my patient into surgery, I need to fix the electrolytes and the acid-base disturbance. I will give fluids, right? I will fix the acid-base disturbance, the electrolyte disturbance. Duodenal atresia, I will do the same. I will fix the fluid, electrolytes, and the pH. Plus, in duodenal atresia, you do something extra, my friends. What is this thing? Hmm. What is it, guys? Either duodenal atresia or pyloric stenosis, before putting them into surgery, I will fix the fluid, the electrolytes, the acid base. But in duodenal atresia, I will do additional thing. No, not genetic exam. It takes long. Very good. This is what I want to hear. Echo. Here for duodenal atresia, I will order echo, echo. Why echo? Because I told you, duodenal atresia is the one of them associated with Down, and Down syndrome is associated with cardiac defects. Having cardiac defect is critical note for the anesthesia team because they will maintain the patient blood pressure during surgery, the cardiac output, and those stuff. So they need to know about cardiac defects. Got it? Okay. Mainly for step 1 Zahra, but if I have some step 2 rapid notes, I drop it. Okay, guys. So let us recap, guys, what we have said. Let us recap what we have said. The family of neonatal vomit. The baby will have excessive vomit, acid-base disturbance, alkalosis, metabolic alkalosis with low chloride, low potassium. The first member of the family, tracheoesophageal fistula. First hours of life. Contents are non-digested milk. Next step, nasogastric tube. It coils in the chest. Second one, and it has polyhydramnios because it is there in fetal life. Pyloric stenosis, it takes weeks to develop after birth. So the vomiting, weeks, 2 to 8 weeks. Contents, digested stomach contents, digested milk, non-bilious. Examination shows hypertrophied pylorus, olive-shaped mass in the epigastric area. You order ultrasonography. Duodenal atresia in Down syndrome, present in fetal life. That's why the fetus has polyhydramnios. After delivery, the vomiting occur early, so early in the first 2 days of life, and it is bilious. Clear, my friends? This is the first family covered. Next. A full-term newborn is delivered with loops of bowel protruding through a defect to the right of the umbilicus. The exposed bowel is not covered by a membrane and appears erythematous from contact with amniotic fluid. The infant was born to a mother with no prenatal care. What is the most likely diagnosis? A new family, guys. Family of ventral wall defects. Ventral or abdominal wall defects. How to master the family, guys? How to master the family of ventral wall defects? You will master the family, my friends, by asking yourself those questions. Where exactly is the defect? And I mean by where, its relation to the umbilicus. Is it behind the umbilicus or lateral to the umbilicus? Question number 2. That defect you see by your eye, is it covered or not? Is it covered or not covered? This defect you see by your eye, covered or not covered? And if covered, covered by what? Covered by transparent membrane, covered by skin. Question number 3, and less important, association. Association, okay? Let us apply my rules. The first defect we have here, my friends, is gastroschisis. The first defect here is gastroschisis. Gastroschisis, guys, herniation lateral to the umbilicus. Huh? Covered or not covered? I see the intestine by my eyes. I see the intestine clear by my eyes. So not covered by anything. Question number three. Is it associated with any syndrome? No. Not associated with any syndrome or any chromosomal abnormality. It is isolated defect. Clear, my friends? So lateral to the umbilicus. Question number two, not covered. Number three, not associated with any chromosomal abnormality. So, guys, when I study this personally, I make mnemonics for myself. I do not wait for someone to give me mnemonics. I make a mnemonic for gastroschisis called no or not. So not associated with anything, not covered, and not behind the umbilicus. Not behind the umbilicus, because the other defects are behind. Not behind, not covered, not associated with chromosomal abnormalities. Okay, no, no, no. The second defect, my friends, is this one here. Omphalocele. Omphalocele. Omphalocele, my friends. Let us apply my questions, my rules. Where is it located? It is behind the umbilicus. It is behind the umbilicus, my friends. Okay? Behind the umbilicus. Covered or not covered? Yes, covered. Covered by what? I see transparent membrane and I can clearly see the intestine inside the membrane. So covered by membrane. Number three, the association. It is associated with syndromes. Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome. And sometimes you can see it in Down syndrome also. Beckwith-Wiedemann syndrome. And sometimes you can see it in Down and sometimes in Patau. Clear, my friends? That is the second member of the family. The third member of the family, guys, the third member of the family, congenital umbilical hernia. Umbilical hernia. Let us apply our questions here, guys. Let us apply the questions. Where exactly is the defect, guys? Behind the umbilicus, right? It is behind the umbilicus. It is behind the umbilicus. Is it covered or not covered? Yes, I see it covered. Covered by what? I cannot see the content inside. That is skin. Skin. I cannot see what's inside the skin. Covered by skin. Association. Huh? That hernia, guys, is associated with Down syndrome, okay, and hypothyroidism. Down syndrome and congenital hypothyroidism. Down syndrome and congenital hypothyroidism. And for step two students in the life, for step two students, USMLE step two loves umbilical hernia. Okay? They love to ask about the management. The management, observe till the baby is 5 years, as long as it is small, smaller than 1.5 centimeters, and not incarcerated. And by the way, guys, USMLE loves anything that is answered by reassurance observation. So whenever you study, my friends, any file, any book you study, go to the search mark and type observe and memorize anything that come after observe. Because the easy thing, if you tell me some symptoms, oh, you have a disease, that is the easy thing. The difficult thing, which tells us you studied hard, is you stop. No, those those symptoms. Okay, I can observe. I will not do any intervention now. Okay, my friends, this is the second family are done. The third family. A 2-month-old male infant is brought to the clinic for right-sided groin swelling that becomes more prominent when he cries or strains and decreases when he's calm or lying down. The swelling extends into the scrotum and is soft and reducible on examination. There is no overlying skin discoloration or tenderness. What is the most likely diagnosis, my friends? Yes, my friends, indirect inguinal hernia. Indirect inguinal hernia. Okay, we have a new family here, guys. Inguinal masses. Inguinal masses, hernias. First, before telling you about the details, let me tell you how the question stem will come. The first 3 or 4 lines in the question stem. Or in medical practice, how hernia comes to you. This is hernia, inguinal hernia, my friends. There is the intestine is herniating outside to the scrotum. So the patient can come to you 2 times. The patient can come to your clinic if the patient is lucky, or the patient can come in emergency to the emergency department. To the emergency department. Okay? If the patient is lucky, guys, will come to the clinic like this. Doc, old person. I notice whenever I cough, I feel a mass protruding through my scrotum. Or mother bringing her baby boy, during changing my baby diaper, I notice scrotal mass or scrotal swelling. If they are lucky. Okay. If they are not lucky, my friends, if they are not lucky, they will come with incarceration, trapping. You know, guys, this hernia, this intestine loop, it gets outside, then gets inside again. Okay, reversible. Outside, inside. But at a time, it will go outside and failure to retract. Not able to retract. That is trapping. That is incarceration. So the patient will come to the emergency department with signs of a small bowel obstruction. The patient has abdominal distension, abdominal pain, vomiting. You auscultate the abdomen, high intestinal sounds, and the scrotum is tender. The scrotum is swollen. You hear intestine sounds in the scrotum. That is the scenario of incarceration. Clear, my friends? This is the presenting part in the question, the upper 3 or 4 lines. Then for step 2, step 3, they will ask you about the management. Okay, management. Next step, is it diagnosis? Is it treatment? You do what? Emergency, not? While step 1 will ask you about anatomy and anatomical relations, basic science, anatomy. Step 1 will ask about anatomical relation. Let me help you with that. Guys, this is your inguinal ligament, okay? This is the inguinal ligament in black. This is the inguinal ligament. The hernia that protrudes below the inguinal ligament here, this is femoral hernia. What do you need to know with femoral hernia, my friends? For femoral hernia, it occurs through femoral canal and exclusively in females. Okay? Femoral hernia, femoral canal, females. Femoral hernia, femoral canal, females. 3F. 3F, okay? 3F. While the one that comes above the inguinal ligament, the direct and the indirect inguinal hernia. Direct inguinal hernia here, medially. Direct inguinal hernia, guys, occurs in all the people. Why? Due to weakness in their abdominal wall muscles, especially transversalis fascia. Weakness in their transversalis fascia. Indirect inguinal hernia, it occurs here laterally, guys. That one affects the boys, the young boys. The young boys due to wide processus vaginalis. Wide processus vaginalis. How to differentiate medial to what, lateral to what? To those high yield vessels in green. Those green vessels here, guys, are inferior epigastric vessels. Those are the vessels that we use to differentiate. Okay? Lateral to the vessels, that is indirect inguinal hernia. In young boys, wide processus vaginalis. Medial to the vessels, that is the direct inguinal hernia in all the people due to weakness in their abdominal wall muscles, weakness in transversalis fascia. Is that clear, my friends? This is how USMLE Step 1 will ask you about hernia. And this is, guys, I want to tell you about one thing. Whenever you study, guys, it is not enough to just memorize the concept. You need also, to learn. You need to learn how USMLE ask about it. How USMLE ask about it. So, and this is what I'm giving for you here. Question stem like this, you tell yourself, okay, USMLE will bring me the lucky boy or the lucky patient to my clinic with mass in the scrotum. Or unlucky will come to emergency department with trapping, with incarceration. Then USMLE will ask me, step 1 will ask me about relations. Below the inguinal ligament, that is femoral hernia female. Above the ligament, direct and indirect inguinal hernia. They are separated by inferior epigastric vessels. Lateral to the vessels, indirect one in boys, young boys. Medial to the vessels, direct one in all the persons due to weakness in transversalis fascia. Clear, my friends? Okay. Let's go to a new family. A full-term newborn develops severe respiratory distress immediately after birth, with tachypnea, cyanosis, decreased breath sounds on the left. The abdomen appears sunken on physical exam. Chest X-ray reveals air fluid bowel loops in the left thoracic cavity with mediastinal shift to the right. That's very interesting. Okay, what is the most likely diagnosis? Yes, my friends, congenital diaphragmatic hernia. Guys, this is the family of neonatal respiratory distress. Neonatal respiratory distress. Okay? Neonatal respiratory distress. You find a neonate, guys, with non-specific signs of respiratory distress. What is your next step? My next step is ordering chest X-ray. What are you expected to see at level of USMLE? I'm expected to see three diseases. The first disease, my friend, will be bilateral. This is what the X-ray will show me. Bilateral pulmonary hypoplasia. Bilateral small lungs. Bilateral pulmonary hypoplasia. Then this is what, guys? This is what? Hmm. This is Potter sequence, right? Then this is Potter sequence. So, neonatal respiratory distress, you order X-ray, you find bilateral pulmonary hypoplasia. You suspect what? Potter sequence. The baby is not able to swallow, less amniotic fluid volume, less amniotic fluid going to the lung. The lung will not be expanded, the lung will not grow. Okay? That is the first scenario. The second scenario, my friends, the second scenario, I order X-ray and I see this. I order X-ray and I see this. Bilateral opacification. I do not have white color, guys, okay? Bilateral white opacification. Then this is what? Especially in premature kid, preterm. Preterm. Then I suspect neonatal respiratory distress syndrome. Then in this case, I suspect neonatal respiratory distress syndrome, bilateral opacity. Why? The baby is born preterm, less surfactant inside the alveoli. So no surfactant in the alveoli will collapse. Collapse means no air, it will look white. Okay. The third scenario you will see, and this is our topic for today, since this is GI, you will see good right lung. Okay. Okay, you will see good right lung, but the left lung is small. Oh, what is that? Right lung is normal. Okay, left lung is small, and you might see some deviation to the right. What is that? Yes, that is congenital diaphragmatic hernia. Congenital diaphragmatic hernia. Guys, what happened here in this disease? There is a defect in the diaphragm. Defect on the diaphragm, guys, that allowed the intestine contents, GI contents to go to the thorax, left thorax. Okay, and they compressed the left lung, impairing left lung growth and expansion. Impairing left lung growth and expansion. So when you order X-ray, guys, you will see small left lung. You can see mediastinal shift to the opposite side. You can see loops of intestine, loops of intestine. Also, when you auscultate the chest, you can hear intestinal sounds. Auscultation of the chest, you can hear intestinal sounds. Okay? Let me show you the X-ray, guys. Look at here. This is the lung. While the intestine loops here, I see loops of bowel. Loops of bowel, okay? Loops of bowel. All right. Clear, my friends? By the way, USMLE Step 1 loves to ask about anatomy and embryo facts in the form of pathology. So instead of coming to you and asking you, what is the origin of the diaphragm? What is the origin of the diaphragm? And you tell me the diaphragm comes from pleuroperitoneal membrane. No, 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 no. USMLE will give you congenital diaphragmatic hernia. And they tell you the pathology behind this patient disease or this patient symptoms is due to failure of what? Failure of pleuroperitoneal membrane formation or fusion. A problem with pleuroperitoneal membrane. Got it, guys? Defect in pleuroperitoneal membrane. So USMLE will integrate it with embryo. All right, my friend. So please, guys, tell me if everything is clear to now, and please tell me if you got how you study GIT. Families like that. You memorize the general picture of the family, like neonatal non-specific signs of respiratory distress, then the specific key for each subtype of the family. How will Potter sequence be like? How will congenital diaphragmatic hernia be like? How will neonatal respiratory distress alveolar collapse be like? Clear? Okay. Now, guys, we wanna practice some questions together. Let me share my screen. Okay. Let us read, guys, and you answer, please. Guys, when you pass over a question, you read the last line. Which of the following is the most likely cause? Okay, they are asking about pathophysiology or diagnosis. And if they give you labs, you read the labs. And the choices, you go rapidly by your eyes through choices to see what chapter is this. What chapter are they asking me about? What family? What family are they asking me about? Like, if I notice things about the subtypes of neonatal respiratory distress, oh, then my brain is systemic now. Family, they are asking about the family of respiratory distress. So the keys will come to my mind. I know the keys of pulmonary hypoplasia. I know the keys of congenital diaphragmatic hernia. I know the keys of alveolar collapse. Okay? All right. Okay. Which of the following is the most likely cause of this patient condition? Compression of the intestine, colon perforation, intestine, gallstones. Okay. Scenario of abdominal pain. All right. White disease, normal. No, white disease, little high. Hemoglobin normal, platelets normal, sodium, okay. Relative, sodium low, potassium low, that is more important to me. All right. Chloride low, bicarb high, BUN high. All right, let's read the question. A 56-year-old woman comes to the emergency department with 18 hours of progressively worsening crampy abdominal pain. Crampy abdominal pain, okay. Abdominal distension, nausea. She has vomited multiple times and has not passed flatus or had bowel movement since symptoms started. Her medical history is significant for open total abdominal hysterectomy 6 years ago and laparoscopic cholecystectomy 12 years ago. She had no abdominal symptoms since that time. Temperature normal, blood pressure normal, little normal, pulse little high, saturation normal, abdominal examination shows diffuse tympany, okay, and diffuse tenderness without guarding or rebound. Bowel sounds are high pitched, okay. What is the diagnosis, my friends? Or what is the pathology? Yes. Very good, guys. Choice A, right? Very good. What is the point here, my friends? What is the point here? Guys, people with prior abdominal surgery, it will heal with fibrosis. They will have fibrous bands inside. The fibrous bands, my friends, sometimes will compress the lumen of the intestine and the patient has small bowel obstruction. So the patient years later will come to you with abdominal distension, signs of non-specific signs of a small bowel obstruction. Okay? So the patient will come with abdominal distension, abdominal pain, tenderness. You auscultate the abdomen, high intestinal sounds. You order X-ray, you see air fluid level. You plus having the prior abdominal surgery history, then this is adhesion. Adhesions, fibrous bands causing mechanical small bowel obstruction. Mechanical small bowel obstruction. Clear, my friend? So important to know, guys. Years before. It comes in the differential diagnosis of paralytic ileus. What is paralytic ileus? After surgery, my friends, days. the days following the surgery, like mostly the first 3 days. The GI is paralyzed from anesthesia, from electrolyte disturbance, from the opioids that the patient took for the operative pain. Okay, they can induce paralysis in the colon, and they can come with distension, but it is not painful. Intestine is hypoactive, so low intestine sounds. Both the small intestine and the large intestine are dilated, while the mechanical obstruction, small intestine is the only dilated one. Okay? Paralytic ileus comes early, first 3 days. Mechanical small bowel obstruction comes years later. Okay? All right. So this is how you differentiate between them. And by the way, I will take this chance to tell you about our QBank. Guys, as I told you earlier in the session, since step one became pass or fail, we expected that QBanks in the market, they cut down the content. They cut down the content, the courses in the market, they cut down the hours, which did not occur. That's why we made this QBank, guys. We focus on the most high yield asked contents in different self assessments. Okay? Only the high yield asked ones, not anything else. And that ended up with having 1,000 questions and like 1,400 questions, which you can finish in 1 month. 1 month if you're dedicated, 2 months if you're starting in early prep. That is the first point. The second point, my friends, most of our questions have tables. Table in the answer explanation. Tables comparing between the things that come together in the choices and you're confused between. Like some of you guys will come to me, Doc, I ruled out or wrong answer. I excluded C, D, E, or whatever. And I ended up having two choices. First choice, mechanical bowel obstruction. Okay, the mechanical obstruction, and the second choice, paralytic ileus. Then it ended with picking the wrong one. Yes, because those are the two confusing similar ones. Each one has its specific key. So we made table for that. To fix the very common USMLE problem with the students, I exclude all the wrong ones till I have to, and it ends by getting it wrong. This is the second benefit of the QBank. The third benefit, guys, AI chat. You will tell me, oh, I have a ChatGPT, I have free ChatGPT. Yes. But for me to use the ChatGPT, my friends, okay, I will open the question, then I will write to ChatGPT, there is a question asking me about blah, 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 blah. Okay, help me with the question. That will take time. Our AI is built and integrated with the question. Our AI memorizes the question. And no need to write. You just pick. We are saving your time to the most. You just pick summarize. You just pick why am I wrong. You just pick, show me the specific keys that I'm talking about since 1 hour till now. Just press it, guys. We are saving your time to the most. Plus tutor support, we hold the daily life as you see here. Like any question you have, guys, in any chapter or regarding USMLE preparation, I will happily answer. Plus, my friends, we have flashcards. Ready-made flashcards. No need to make flashcards. You have ready-made. If you like it, you just save it. Like you can press it, guys, like this. You can add edits if you want. If you have additional note, you can add it. And then you save it. So to save your time, ready-made flashcards plus notes section, of course, if you want to take notes for yourself. Clear, my friends? And I tried it with many of my private students, guys, and I have exam passes and self-assessment passes. So we have not started it for too long, but like months ago, 3 or 4 months ago, but yet we have students finished it and passed exams, and other students finished it and passed their self-assessments, and they are in the booking process. Okay, guys? Next question. Which of the following is the most likely underlying cause of this patient's symptoms? I see autoimmune destruction of the small intestine, colon mucosa inflammation, enzyme deficiency. So I think something related to malabsorption syndromes and diarrheas. This is what comes to my mind. Then I will look to the table. Hemoglobin, okay. MCV is okay. Leukocyte count, okay. Platelet count, okay. CRB, okay. All labs are normal. Let's see. A 26-year-old woman comes to the clinic because of 6 month history of intermittent lower abdominal discomfort and loose stool. Okay. She reports 3 to 5 bowel movements per day. The stool are non-bloody. That is important for me. She sometimes feels an urge to defecate. and notes that her symptoms can fluctuate. All right. The discomfort may improve after bowel movement. That is important to me, but not always. She's unsure whether specific food consistently triggers her symptoms. She takes no medication and she has not traveled recently. Physical exam shows moderate tenderness in the left lower quadrant without guarding or rigidity. Physical exam is normal and stool Guashiak test is negative. What is that, my friends? Hmm. All inflammatory markers are normal, all labs are normal, there is no blood, the symptoms worsen after meal, shows some improvement with defecation. What is that, my friends? Hmm. No. Visceral hypersensitivity. IBS owner, IBS no, this is USMLE owner. This is a good question, by the way. This is a good question. Okay. You might think, oh, she has pain in the left lower quadrant. That takes me to diverticulitis. Diverticulitis is infection, so the patient should have fever leukocytosis, which is not present here, owner, right? And you need to expect that from USMLE questions, guys. They will not give you clean, perfect scenario because the patient presentation in real life is not clear, perfect presentation. So yes, I can confuse you with some symptoms related to other diseases, like I tell you here the pain is only in the left lower quadrant. You get me? But I have more important case. The symptoms worsen after eating, improve with defecation. No alarm features. Okay? All labs are normal. Everything is good. So that takes me to irritable bowel syndrome. All right. Okay. By the way, guys, USMLE ask about irritable bowel syndrome in two ways. The first way, what is the diagnosis? I will give you the symptom and I will ask you what is the diagnosis. Like what? You have a patient with history of anxiety or stress, have abdominal pain after meals that improves with defecation. What is the diagnosis? IBS. And all the labs are normal as you see, because this is a physiologic disease. Question number two, and more important than question number one, alarm features of irritable bowel syndrome that tells you, oh, this is not IBS. This is some other disease. Alarm features of IBS, my friends, asked in step one, step two, step three questions. If you see blood in the stool, if you see weight loss, if you see high inflammatory markers, ESR, CRB, and more importantly, calprotectin. If the symptoms at night not related to meals, then I order colonoscopy looking for other diseases like inflammatory bowel disease. Got it, my friends? Okay. And of course, there is a table here differentiating similar diseases together. There is irritable bowel syndrome. All markers are normal, improves with defecation, right? Always you will find inflammatory bowel disease in the choices, and USMLE bring you inflammatory bowel disease to test you. Do you memorize the alarm features or not? And those are the alarm features. Okay? High inflammatory markers, blood in the stool, anemia, okay? Weight loss, symptoms at night, for which you order endoscopies. Celiac disease, my friend. Celiac disease, as you know, people who have gluten hypersensitivity. Huh? Then they have damage in the mucosa of their duodenum. Mucosa in their duodenum. They will have fatty diarrhea. And by the way, guys, I told you earlier that literally each assessment has a question from fatty diarrhea. Okay? Either the risk factors or the complication. Let us start by celiac disease. This is the first one causing fatty diarrhea. Fatty diarrhea, guys, means the patient will lose weight. Fatty diarrhea, loss of fat, the patient loses weight. The patient will report in the question stem that the stool is difficult to flush. Stool float over toilet surface and difficult to flush. Number three, the patient loses fat soluble vitamins. Losing fat, the patient will lose fat soluble vitamins A, D, E, K. So they can give you any of those vitamins deficiency symptoms. Clear, my friends? That is celiac disease. It will be fatty. While irritable bowel syndrome, it is not fatty. It is not fatty. It is watery. Okay, not fatty, not fatty. All right. Lactose intolerance. Those who have deficiency in their lactase enzyme, especially those who had recent gastroenteritis. Their symptoms are triggered by dairy products. Dairy products. But actually, USMLE will not always tell you the patient had dairy products. They will just tell you meal. The patient had his meal, and after meal, he has watery diarrhea and cramps. People with lactose intolerance, my friends, they drink milk. They have lactose, but they cannot digest the lactose. They have deficiency in the lactase enzyme. The bacteria in their GIT will ferment the lactose releasing two things. Gas, which would give bloating cramps, uncomfortable sensation, and acid. Acid will give watery diarrhea and acidic stool. Watery diarrhea and acidic stool. Watery diarrhea and acidic stool. Clear? That is lactose intolerance. That is lactose intolerance. Is that clear, my friends? And those are the diseases that come together in the choice. Choice D, as I told you guys, all the choices are high yield. All of them are high yield. Chronic pancreatitis, super, super, super high yield. Most assessments has a question from chronic pancreatitis. Chronic pancreatitis, my friends, mean the patient lost his pancreas from recurrent episodes of pancreatitis, from alcoholism, okay, um, from cystic fibrosis, What will happen if the patient lose the pancreas? That means the patient will lose the lipase enzyme, leading to loss of fat, right? Loss of fat digestion, fatty diarrhea, loss of fat soluble vitamins E, D, E, K, weight loss of trypsin enzyme, trypsin. So losing protein, weight loss of bicarb, so acidic duodenum, having pain after meals, because normally, guys, our pancreas after meals contracts to eject fluid. Contraction of atrophied calcific pancreas like this patient is extremely painful, right? And we treat it by supportive treatment, like you give pancreatic enzymes and you give fat soluble vitamins E, D, E, K. Is that clear, my friends? Please tell me, guys, if you have any questions for me. We are done, guys. We are done together for today, and I will see you in the upcoming webinars. Any questions, guys, before we end? Whenever you want help, guys, you text the support team, you reach to us. We are ready to help you anytime. If you want help regarding plans, schedules, or if you want a mentor to guide you day by day, we have different mentors. First session is free. You can book your free session with two different tutors and see which one you like and you proceed with. Also, the QBank, guys, there are 40 questions for free. You can create an account, enjoy 40 questions, and you see if you after doing the 40 questions if there will be improvement or not. Okay, guys. Um, thank you guys for your energy. Thank you for your questions, and I will definitely see you later for the upcoming webinars. The links in the chat. Okay, guys. Have a good day. Bye bye.